So we'll be talking about the drug-induced kidney disorders, which is a huge area and a growing problem worldwide. Now, the kidneys metabolize and or excrete many agents. These agents can be therapeutic, diagnostic, environmental, herbal, illicit, like Abdurrahman showed you one of the examples, or food additives. Now, the injuries are due to patient-related, kidney-related, or drug-related factors. Thank you, sir. And the injury can be renal-limited, AKI, acute kidney injury, chronic kidney disease, chipolopathy, nephrotic syndrome, hypertension, or systemic from the toxicity of the drug or its metabolites accumulation in those patients with reduced kidney function, whether it's acute or chronic. So we'll be talking about these agents, the risk factors, the kidney disorders, and how to deal with this problem. Now, the nephrotoxic agents can be therapeutics that can we give the patients and we cause the problem, antibiotics, chemotherapy, and analgesia, immunosuppressives, even fluids. We've all known that infusion of large volume of normal saline or starch can cause kidney injury. And many others, including the ACRBs. Or diagnostic, the iodinated contrast, the gadolinium, the oral sodium phosphorus, purgative for colonoscopy or others. Alternative medicine. The aristolochic acid was caused the Balkan nephropathy and the Chinese herbal nephropathy. It's been worldwide now. The others, other herbal medications. The problem with the herbal market is unregulated. It's without control at all. These herbal agents can be themselves directly nephrotoxic. I'm not sure if there is or they interact with medications, converting them into toxic agents, or are adulterated with nephrotoxins. They give you a herbal agent saying this is a benign analgesia, when in fact it's loaded with profen or other non-steroidals that can cause acute kidney injury. The others are environmental, whether the sky we walk under, the ground we walk on, the water we drink, the food we eat. Don't trust your governments. It's filthy all around us. So heavy metals, solvents, herbicides, coppers, illicit drugs, heroin, cocaine, solvent inhalation, amphetamines, cannabis, all these can cause all sorts of drug medications. And finally, food additives. I'm not talking about these tiny numbers. I'm talking about food loaded with salt for longevity and loaded with phosphate for taste. And these are extremely dangerous for patients with chronic kidney disease. They can accelerate the progression of CKD, worsen hypertension, aggravate bone mineral disorders, and increase cardiovascular risk in those patients. So, what are the risk factors? Let's start with patient-related factors or patient-specific. The gender and the age. In females, excuse me, in females and older people, the low total body water and the low lean body mass may result in overdosing. The unrecognized low GFR in this group may also result in overestimating GFR and giving an overdose. The low albumin reduces the protein binding, increasing the free drug level. Renal vasoconstriction from excessive angiotensin II and endothelin activity in the elderly. The underlying kidney dysfunction, whether it's acute or chronic, can also result in increased risk of kidney disorders because of excessive dosing. Metabolic derangements, hypokalemia, hypomagnesemia, hypocalcemia, they can increase the toxicity from drugs. Abnormal urine pH can result in precipitation and increased toxicity. Methotrexate, for example, indinavir or Topamax can result in different kind of crystals or stones in different parts of the GU tract. Also, the underlying health status of the patients, whether there is an acute or chronic condition, not necessarily renal disorder. Hyperperfusion, whether it's a chronic from low ejection fraction or from true volume depletion, can result in excessive drug dosing, intracellular accumulation, in the proximal tubule cells and the precipitation of drugs in the distal tubule. Hypoalbuminemia again, and unrecognized low GFR and high bilirubin levels. And the host genetic makeup. Why patient develops acute interstitial nephritis when another patient who's exposed to probably higher dose and longer course does not. It's the patient's genetic makeup. The innate immune response genes enhance drug-induced acute tubular interstitial nephritis in some. The pharmacogenetics cause heterogeneity in the drug efficacy and toxicity. The cytochrome P45 mutations, loss of function mutations can result in increased risk of drug-induced kidney disorders. What about the kidney-related factors? Of course, the high renal blood flow, 20 to 25% of the cardiac output, so there is a huge exposure. The high metabolic rate of the relatively hypoxemic medulla of where the limb of Henle is result in the high risk. The concentrating ability means that you also can concentrate nephrotoxins. The metabolism of the drugs, some drugs are metabolized into toxins in the kidney. And the uptake in the proximal tubules, these proximal tubule cells take these drugs and accumulate in the cells, which means that they are exposing themselves into a high level of nephrotoxicity. What about drug-specific factors? The extended course, the high dose, or the rapid infusion of the toxin can be one factor. Concurrent administration of nephrotoxins. You give a patient with, let's say, mild CKD, aminoglycoside, non-steroidal, and contrast, and you say, well, I'm not sure why did the patient develop acute deterioration of renal function. The drug competition of the proximal tubule secretory transporters and the solubility of drugs and their metabolites in the urine. The urine pH, the flow rate, the dose of the drug, and the solubility all can enhance distal precipitation. So what about these drugs that can happen? Well, acute kidney injury, chronic kidney disease, tubulopathies, nephrotic syndrome, hypertension, the accumulation of toxic metabolites, and of course, diabetes, the risk of diabetes. So, acute kidney injury. Well, there's no standardized definition of drug-induced acute kidney injury. Some used in the past the rise of 44 micromole or 50% rise in creatinine over 24 to 72 hours after exposure. But the KDIGO classification now, it's 0.26, and it's acute less than 7 days, subacute less than 3 months, or chronic after that. It's difficult to recognize drug-induced acute kidney injuries in the presence of other factors, especially those patients who are acutely ill or undergoing so many other things. You need to know the mechanism of injury, the time period, and the onset of injury. But again, the acute kidney injury, as the classic teaching, can be pre-renal, renal, and post-renal. So pre-renal, either afferent vasoconstriction from non-steroidals and calcineurin inhibitors or contrast, or efferent vasodilatation from the ACE-ARBs. Intrinsic tubular injury can be necrosis from aminoglycosides or crystal precipitation from acyclovir, glomerular thrombotic microangiopathy, there's a long list of drugs, or actual vasculitis from xyluric, hydralazine, and others. Acute tubular interstitial nephritis. More than 3/4 of the cases are drug-induced. There are others, infectious and autoimmune, but it's mainly drug-induced. And vascular injury, cholesterol atheromboly, for example. Just briefly about drug-induced acute tubular interstitial injury. Now, although more than 75% of cases of acute tubular interstitial injury are due to drugs, it is seen in less than 1% of patients who are receiving drug, which is good. I mean, there are millions and millions of people on drugs, and if you're going to see it in a high rate, that's extremely dangerous. Can be antibiotics, non-steroidals or COX-2 inhibitors, the GI medications, whether it's PPI or methazalazine, diuretics, chemotherapy, and others. Okay, sorry. The triad of rash, fever, and eosinophilia is uncommon. You shouldn't depend on it. And the urinary abnormalities of eosinophilia is also unreliable. Forget it. Biopsy, whether for diagnostic, prognostic, or therapeutic reasons, will show you an acute injury in less than 50% of the cases. Most of them we're going to show you some progressive form of chronic disease, basically because delayed in diagnosis or the injury was so severe. And the recovery is not that common. It's probably around more than 2/3. Steroids are useful if given early, whether oral, whether IV then oral or just oral. So post-renal can be due to stone formation, urine retention with the anticholinergic drugs, or retroperitoneal fibrosis. What about tubulopathies? Well, the proximal tubule can have Fanconi syndrome or just isolated proximal renal tubular acidosis. With the loop of Henle, you can have salt wasting with cisplatin or Bartter-like syndrome with gentamicin. With the distal nephron, you can have nephrogenic DI with lithium, hyperkalemia with the reduced aldosterone synthesis or aldosterone antagonism or ENaC, epithelial sodium channel blockers. You can have magnesium wasting with the endothelial growth factor receptor antibodies or distal hypokalemic renal tubular acidosis. Nephrotic syndrome, again, you can have minimal change disease with non-steroidals. And you can see that some drugs can cause different disorders. They're not necessarily, for example, non-steroidals can cause minimal change disease or can cause minimal membranous nephropathy. And lithium can cause minimal change or FSGS, probably more likely FSGS. What about chronic kidney disease? Lithium, calcineurin inhibitors, aristolochic acid in the herbal medications, nitrosourea and chemotherapy, lead, mercury, cadmium, these environmental nephrotoxins that many are ignoring that they are being exposed, and food additives. Now, what about drug-induced hypertension? You've got hypertension due to volume retention from non-steroidals or estrogen and progesterone or steroids. You've got sympathomimetic activation from cocaine, attention deficit hyperactivity disorder, psychostimulants, or tricyclic antidepressants. You've got direct vasoconstrictors, calcineurin inhibitors, and you've got other mechanisms, erythropoietin, alcohol, and dietary supplements of ephedra and others can cause hypertension from different mechanisms. Now, what about the accumulation of active or toxic metabolites in CKD? Patients with advanced CKD can accumulate the paracetamol metabolites, which are hepatotoxic, the codeine and morphine metabolites, which can have prolonged narcotic effect, theophylline metabolites, which are cardiotoxic, mycophenolate metabolites, GI toxic, clofibrate metabolites, muscle toxic, immunosuppressive activity of azathioprine, and the sulfonamide metabolites toxicity. So it is extremely important to know that. And diabetes, why I'm concerned with diabetes? Well, diabetes is the leading cause of CKD. So there are drugs that can cause both CKD and diabetes, like calcineurin inhibitors, and that drugs that cause diabetes are given to patients with CKD. So treating one disease when in fact causing another disease, like diabetes, which is worse. And these drugs can cause insulin deficiency, like calcineurin inhibitors, insulin resistance, like growth hormone, or both, like the atypical antipsychotics and steroids. So what do we do? How to prevent injury and reduce the risk? First of all, we should all be aware of the side effects of drugs. You cannot just give medications when you actually don't know what they do. You should be knowledgeable on the mechanisms of the drugs and their side effects. And we should communicate with pharmacists, hospital and community, and we should educate patients. We should also identify, when you know the side effects, you should identify patients at risk. The elderly, the volume depleted, the polypharmacy, to start looking at serious adverse effects. Take precautions if you cannot avoid that nephrotoxic agent. Monitor creatinine and urine output and make sure that the patient has good urine flow. Adjust the dose and frequency according to the GFR and follow levels. Avoid drug interactions. Ensure adequate volume status. Address other risk factors for kidney injury. Blood pressure, blood sugar, hemoglobin, other toxins. Give protective agents and avoid repeated exposures over a short period of time. What about the patient who already developed the kidney disorders? How to respond? Well, the response depends on the severity of the injury, the type of injury, the underlying condition of the patient for which the drug was given, and the availability of alternatives. So, stop the offending agent, and if there is an alternative, use the alternative. Consider biopsy for diagnostic, prognostic, and therapeutic reasons. Desensitization has not been established in drug-induced acute supraintestinal nephritis, and correct other risk factors and complications, electrolyte and acid-base disorders, anemia, and blood pressure problems. Now, for hepatologists, they have this kind of form to assess causality. Unfortunately, we don't have that in nephrology, although it would be very useful to look at all the factors and look at the condition and see whether it was responsible
2 minutes
or not.
to run.
Seriously? They are enjoying the talk. I'm going to take 5. Okay, so replacement therapy. Start kidney replacement therapy dialysis when indicated to remove the harmful drug or, to replace renal function. The removal of drugs by dialysis depends on the drug molecular weight, the protein binding, the volume of distribution, and the dialysis modality. Now, the dialysis will affect drug dosing, so you need to monitor that if patient is on other drugs. And what about rehabilitation? Now, rehabilitation means don't forget the patient after discharge. They had an injury, whether it's an acute or chronic. You need to monitor their recovery later on. Follow up to monitor the GFR, the blood pressure, the tubular function. And always document in the file and with the regulatory authorities to ensure the patient is not exposed to the offending agent again. Okay, so in conclusion, the kidneys are exposed to a diverse group of nephrotoxins which can cause a variety of renal disorders. With the rising rates of chronic disease, with the high morbidity and mortality rates of chronic kidney disease, we need to be aware of these medications, of their toxicities, especially with an aging population and increasing polypharmacy. Involve the doctor, the pharmacist, the public in risk education programs to reduce exposure, use electronic alert systems, implementations of steps that I mentioned to reduce, to avoid or reduce the risk of the drug-induced kidney injury. And these are some of the references you need. And with that, I thank you for listening. And
Thank you, Dr. Ali.